Very good evening to you, because we have now morning in Germany. Thank you for the invitation. Today, our topic is going to the question how to manage patients who have really very complex anatomy and bifurcation lesions belong to this complex lesion set, how to manage such patients if they have additionally high bleeding risk situation. This slide. We have to find finally some area here where we have low ischemic events, but not really increase of bleedings. If we treat our patients with DAPT, and this is a standard after PCI, and we know from many studies, from longer term studies, that if we have really very complex anatomy and very high vascular risk, then we have more events compared to bleeding. However, in last 5 to 10 years, we saw that bleeding is in general more and more significant and important topic. And we know also from many studies, and this is one from circulation many years back, but we know this: if we stop therapy, if we stop DAPT, then we have definitely significantly increased risk for stent thrombosis. So according to the current data from our current summary from guidelines, European guidelines, we know we have to treat patients with stable coronary artery disease after PCI without indication for OAC and NOAC, with aspirin and clopidogrel. And if we have very high bleeding, then maybe just 1 month, but this is to be see indication. And you could also use in daily practice some scores. What we use, what we definitely implemented in our center is precise DAPT score. It's quite easy to manage this score, and then you can make additional decision how long should DAPT be performed. And if you go to patients with in stable coronary artery disease and indication for anticoagulation, you see that's again a huge problem. We don't have really enough clear data. And what is really very important, if you have, you should never do triple with ticagrelor and prasugrel, aspirin, and anticoagulant therapy. This is really, we saw few such cases in daily routine, so really increased risk for bleeding. And of course, acute coronary syndrome is a very important topic, because especially in Asia, you have many patients with acute coronary syndrome. So this is, if you don't have high risk bleeding, so you can go up to 12 months with dual antiplatelet therapy. If you have high bleeding risk, so you could go up to 3 to 6 months. And it was the question, can we use some specific stents who maybe bring us to better results according to the lower risk for bleeding? Maybe we could be very sufficient on treatment. And if I mention, we have now to go with studies to show really benefit for 1 month DAPT therapy after PCI. And Onyx 1 global study was a prospective multi-center study which investigated more than 1,000 patients with in the study arm with Resolute Onyx, just to show The 1 month DAPT therapy is, after resolute onyx therapy, safe for our patients. And the comparison was done with Biofreedom, which was one of the best stents for this topic, short DAPT. And which patients were included? You see, in majority of cases, all the patients with age over 75 years. Then renal failure was really very important, anticoagulation, planned surgery, anemia, hospitalization for bleeding within 1 year per PCI, and also some problems with liver disease. The study could show that in the Onyx 1 global study, the results were very clear. After using Onyx stents, we had primary safety endpoint, cardiac death, MI, and stent thrombosis in 17.1%, after Biofreedom 16.9%. So non-inferiority endpoint was met. So it means Onyx, resolute Onyx stent as safe as Biofreedom, which was primary the stent for such patients. But, and here you can see also in few Kaplan-Meier curves, the results for combined endpoint, no difference over 24 months, so 2 years follow-up, cardiac death, no significant difference, MI, no significant difference, and stent thrombosis, no significant difference, but numerically some trend to better results after resolute Onyx stent implantation. So it is really a long-term follow-up now for 2 years. And it was interesting how stents are working. And you see procedural success rate or device success, 93% versus nearly 90% by Biofreedom. This was significantly. And there was allowed to make crossover between study arms. So you see, there was also a huge difference. So much more patients with Biofreedom stent had crossover to Onyx stent. And if you just make this landmark analysis after 1 month, you see there was still a very good clinical follow-up for both stents with some trend numerically better results for Onyx. So this was really very reassuring. And finally, we have, of course, if you go in every day to the cath lab, we have to treat around 20 to 30% of such patients. We have to treat bifurcation lesion. And of course, they as we saw, many lectures, and last lecture from Japan, there was a complex geometry. Side branch occlusion should be avoided, and this is a common complication. And of course, optimal stent optimization is most important issue. And if we just go to the left main, we know around 70-75% of left mains have a really diameter larger 4.5 up to 5.75 millimeter. And this is, I think, important point to implant stent with the option to avoid malapposition. And of course, left main disease is usually, in majority of cases, distal, with distal location. And of course, there was limited evidence, but now we have now data from ABC main study, which was presented yesterday by our ABC president, Professor Stankovic, with really unbelievable results. So if we just take a look to the patient's history, and this is just case report, it's all the male with chronic kidney disease, with angiodysplasia of colon, and that's patient is symptomatic, and that's why, because there was evidence of anterolateral ischemia, patients got coronary angiography. And so you can see here, there is a problematic bifurcation, LAD, and first quite large diagonal branch. Some people could say, okay, this is maybe not really from angiographic point of view so significant lesion. There was a circ with some lesion. There is one more lesion in the right coronary artery. So as you can see, you could really go here with FFR management and to evaluate what is really significant. And the right was, according to the FFR wire measurement, okay, but here bifurcation LAD diagonal branch definitely with pathological flow. So we have to go ahead. You can go, of course, with imaging, check anatomy. You see some calcific plaques, eccentric, and even in the bifurcation region, definitely much more fibrocalcific plaques. And decision was done here to go with Dickey crash because diagonal branch was quite large. There was a lot of disease in LAD, so this is also possible way to go in this case. You could also go with Dickey culotte. It will be also option. But take a look how this case was done. This is already a mini crash here, only 2 millimeters protrusion into the main branch. Stent in the side branch was implanted. But first crash. And if we go forward, you see then rewiring, maybe just to show you, it should be not really in the carina region located, the crossing more in the middle of the stent or proximal. First kissing, that's clear. Then stent in the main branch, pod, rewiring, and finally second kissing and final pod. And this is now final result. So you can manage such patients very nicely, going by also complex lesion, but in this case, you have to be definitely sure there is no malapposition, because there is a bleeding patients, and if you have to stop anticoagulation, DAPT therapy, then it will be a huge problem. You saw this one slide to begin my presentation. So after Onyx stent, which was here used because then we have a very clear option to go just for 1 month with DAPT therapy. But in IVUS, you see there is a really perfect apposition, so no malapposition, everything is perfect. And you could be quite sure this patient will be treated very perfectly. So in general, in high-risk bleeding patients, especially for bifurcation lesions, keep it simple. If possible, try to avoid double stenting. Provisional stenting is definitely the best option. However, if you have to manage a very complex and difficult anatomy, pay attention to choice of the stent, then optimal stent optimization is really most important point. And we should really try to get a perfect result without only minimal malapposition. This is, I think, the crucial, most important point, not only in this case, but in general. And of course, stent design play a role. Imaging, as show it here in this case, is very crucial to demonstrate the result is perfect, no malapposition, etc. And here, use of drug after DS, you have here possibility to stop DAPT after at 1 month if needed, if patients could have clinically important significant bleeding. And Professor Stankovic showed yesterday excellent data from ABC main study. Here just a summary slide for clinical data at 1 year. You see excellent data for onyx in complex bifurcation lesions, and stent thrombosis only 1.7, 1.3. I would say thank you for the invitation, and I'm ready for discussion. Thank you so much.